Welcome to Podcast by TechNation. This is a series of podcasts focused specifically on the biomedical and HTM industry. Episodes are added monthly. Listening to each episode is eligible for one continuing education credit from the ACI. At the conclusion of this episode, you will be able to access a link that will take you to a quick survey. You'll be able to download your certificate once you submit the survey. Before we begin today's podcast, I'd like to invite you to save the date for our upcoming MD Expo in Atlanta on April 11th through the 13th, 2022. You can find more details and registration for the show at mdexposhow.com. Podcast by TechNation would like to thank our sponsor, Accruent. Accruent's intelligence for the built environment aims to improve operational efficiency, regulatory compliance, and the quality of patient care, and to drive gains in performance and availability of healthcare assets, including facility and biomedical equipment. For more information, please visit accruent.com. In this episode, we are joined by Al Gresch, Vice President of Healthcare Strategy, and Rick Joslin, Senior Advisor of Healthcare Strategy. Gentlemen, you may begin whenever you are ready.
Well, thanks for joining us today. Appreciate it. We're going to talk about quality management systems in healthcare and the benefits that it can bring to a healthcare organization. I am Al Gresch, the Vice President of Healthcare Strategy for Accruent. Spent much of my career working in the HTM industry, running a large IDN, in-house department for an IDN in the Midwest. Spent a few years in capital supply chain as well. Worked for an ISO for a little bit, and then went to work for Accruent, where I am now. And I spend time helping customers achieve higher levels of performance and implement best practice. With me today is Rick Joslin, and Rick is the Senior Advisor of Healthcare Strategy at Accruent. He provides support to marketing, sales, products, professional services, and customer success. With his extensive industry knowledge, Rick's been in the healthcare industry for over 22 years. He's guided hundreds of HTM, HFM, EVS, and IT departments to implement best practices in their CMMS usage, as well as regulatory compliance initiatives. Rick has published numerous blog posts, webinars, and industry magazine articles on the healthcare industry covering standards, regulations, best practices, and horizon topics. So you bring a lot to the table here, Rick, and thank you for joining us.
Oh, it's a pleasure, and Al, thank you for having me.
So Rick, ever since I got into this field back in the late 70s, there's been some flavor of continuous quality improvement. I recall one that we employed was even referred to as CQI. And I think back to when I was in school, we learned about the Shewhart cycle, which was developed in 1939 by Walter Shewhart. Subsequent to that, the Deming cycle in 1950. Edward Deming, I think we're all familiar with the PDSA model that Deming developed. And then shortly after that, in 1951, the Japanese version of that, or PDCA. And I think in my past, we've sort of run through all of those in some fashion. And each of those has experienced a continued evolution of statistical quality using empirical evidence to always get better. So QMS, what is it? Well, by definition, it's a set of internal rules that are defined by a collection of policies, processes, documented procedures, and records. The system defines how an organization will achieve the creation and delivery of the products and services that they provide to their customers. And of course, those are based on the international standards, organization standard and guidance, ISO 9001. The latest, I believe, was revision of that was 2015. So Rick, please tell us from your perspective what a QMS is.
Well, a QMS, as you mentioned, it's a set of policies and procedures. It's how an organization does what they say they want to do. But it's not just one department, as opposed to HFM wanting to improve availability of equipment. It is a holistic approach by the entire organization, from top level leadership, touching every department, every organization in a multi-site facility. It is the holistic approach of improving and delivering quality to the customer. So you can think of things like, as I say, there's some things out there about patient quality. Well, HFM and HTM, they impact that patient quality. So you can't do one thing in HTM and not do something over in the nursing, and you can't do something in nursing without doing something in the supply chain.
Well, it doesn't sound a whole lot different than what HTM departments have been doing for a long time. It's just a matter of formalizing it, right?
Right. So a lot of the best-in-class organizations, HTM departments, have probably been doing the majority of QMS processes for years. I think the difference between what they're doing now and progressing into the ISO 9001 realm is at that level, it's not just the HTM department. It has to involve every other part of the organization.
Okay. When DNV was first approved as a deeming organization by CMS back in 2008, quality management systems were in line with the conditions of participation, or COPs, right out of the gate, with a focus on improvement and sustainability using ISO 9001 concepts and compliance. And they gave hospitals 3 years to achieve that compliance. So, Rick, can you give us a quick rundown of the regulatory landscape as it relates to QMS?
Sure. So DNV is the only accrediting body in the U.S. healthcare ecosystem that has QMS embedded in it. So what we want to think about is, what else is out there? What does CMS have? What does Joint Commission have? These kind of things. So there's not a lot in here. For example, CMS, they reference quality measures in several areas. Their MDS 3.0, their user's manual for that, but it's not holistic. There's not measurements across the entire healthcare organization. CMS's focus is primarily on patient-related issues, direct patient-related, like medications, patient pressure ulcers, vaccine administration, falls, those kind of things that are people-oriented. So there's really nothing in the QMS regulatory world for the COPs that deal with specifically quality in a service department like an HTM department. Okay. Likewise with Joint Commission references quality in a lot of different areas, but not QMS. So again, it's looking at patient safety. In the leadership section, there's a lot of referencing in there to quality activities in reference to making sure your patients get the right medication. So think of, how many times are you asked your name, your birth date, that kind of stuff when you're at a doctor's office. Those are the manifestations of the Joint Commission kind of, and QMS kind of patient-focused quality activities. But like CMS, there is no holistic approach. Okay, Joint Commission does have in LD 040101, it does reference agreements with a quality improvement organization that is a possibility, and they do reference quality report feeds. But again, these circle back to the QMS or CMS rather, MDS program. So again, not a lot in there as far as how does an HTM department measure and improve quality of the product that they deliver. Okay. So that's
as it stands now. Then what you're saying is DNV a requirement, TJC, they promote it, but as it stands now, not directly a requirement or part of their evaluation process. Is that accurate?
That's 100% accurate. DNV is very, very, very specific. They have a lot of specific 18 different requirements, matter of fact, in their measurement section for QMS. No other regulatory landscape has that level of it. Everything else is kind of precursory.
Okay. So Rick, you know that I'm a huge Simon Sinek follower, so I always like to start with why. So why do you think it's important for healthcare to adopt a QMS, whether they're surveyed by DNV or the Joint Commission, and make that a part of their standard operating procedures?
Well, there's a lot of benefits that come from implementing a QMS. The first and foremost, of course, is it immediately eliminates that us against them. As we talked about, HTM departments for many years have been striving to continuously improve what they do and how they do it. But there's always a roadblock someplace. There's always another department that needs more funding, or another initiative by the hospital that takes precedence. So you don't get this holistic support of improving the process in areas that the HTM department may not be able to directly affect. So it really allows you to take a holistic approach of the whole organization, supply chain, materials and parts supply, acquisition, distribution, nursing needs. All of that has to get involved into a QMS program. So it really allows you to get past that us against them, but then it kind of opens up the door to where your department is more of a partner with everyone else that's delivering service to the patient, to the ultimate customer. So as I mentioned about equipment distribution, how that happens can be improved. That way the equipment gets to where it needs to be better. Tracking parts and parts procurement could be much more streamlined. The administration and leadership support is a big one. There's no circling around how to do things. So you get this interdisciplinary participation into the overall process of goal setting and delivery and analysis and measurements. So it really allows you to get things done in a way that continuously improves what you do.
I recall, Rick, back in even in the 90s and certainly early 2000s, we had, as a component of our medical equipment management plan, a list of quality improvement indicators that we would track and monitor and try to improve on. So it's kind of exactly that kind of thing, isn't it?
Yes, it's a more formalized version of that, is what I'd say, because it's not just the HTM's quality improvement indicators. It's the organization as a whole and how each of these interact with the other. Okay,
so earlier, Rick, I referenced statistical quality using empirical evidence. What do HTM departments need from a data perspective to make that happen?
Well, data standards. Standards across the board in several areas, processes and procedures, but data is the key. If you're calling the same thing 5 different terms, you can't really analyze what's causing an issue. Or on the same note, if your team's not using the data properly, the coding and things, if they're not recording the right data points, then you can't continuously evaluate and improve and analyze your quality initiatives. Okay, so data standards is a big one. The collection of data is another one. You can look at a good 60% of work activity in CMMSs doesn't contain just a basic analysis or basic data points for things like capital asset planning. You're not recording parts or half the time labor. So even without those kind of pieces, let alone the problem, the fault codes and things like that, you just have to have those data standards in place.
Yeah, I'll tell you, in the places where I work, we implemented a very, very extensive data integrity policy that I've shared with a lot of our customers and others in the industry over the years. And part of that was to have clear definitions. First of all, a finite list of codes that we were going to use. Over the years, you add codes to your CMMS for a variety of different reasons to accomplish a particular thing, but those tend to stay in the system over the years, and often there's not a regular cleaning of that to remove codes that you don't use any longer. And so when I first started that process, we had over 150 codes in the system, narrowed that down, cleaned it up, eliminated many of them, and brought it down to a very finite list of codes with clear definitions, and then went through and trained our technicians on what those codes meant and how to use them. And in fact, I've been involved over the last couple of years with a CMMS collaborative that is sponsored by Amy to create code standards. What we've accomplished so far are standardized codes in both the fault code and request code or work order type codes, and again, clear definitions of those, and those are things, because they are recommended standards, that strongly recommend that people adopt. And I know you personally have been involved in an initiative with ASHI where you're doing similar things. Is that right?
Correct. The leading standards bodies in our healthcare industry have really stepped up with realizing the importance and the criticality of having these standards system-wide. So Amy is definitely on the HTM side, taking the lead on that. ASHI is looking at coding assets is their first realm, but also looking at fault codes as part of some other initiatives like RCM and things. Without those standard codes, it's almost a futile attempt to continuously analyze for any kind of quality improvements in any facet of what a department does.
Yeah, something else I've seen used more than I ever have in the past is tracking response times and turnaround times. So most CMMS products today provide the ability to timestamp when a call comes in, when it was responded to, and when it was completed, to give you that kind of data. So that's another set of data points that a department could use for improvement. Have you seen the same thing and working with our customers?
Definitely. Over the years, some of the best-in-class organizations are measuring that. When you look at to me, when you look at the grand scheme of delivery of services inside of healthcare, patient-focused or patient-related areas and activity should take a higher precedence and should take a front seat to those non-patient areas. So you want to have service level agreements in place, which are really nothing more than internal commitments to things like, if I have an issue in a patient room, we're going to respond to that within a certain amount of time so that we can make sure that patient is taken care of. And that should not be the same time as you would for something on the loading dock or in central sterile or something like that. You really want to do those. An area that I wish more sites would take advantage of is surveys. Part of your product quality or your delivery quality should be, are we responding correctly? Are we meeting our SLAs? Are we meeting the needs of our customers? So surveys would allow you to do that, but it also would allow you to start to analyze like repeat issues or things that didn't get resolved first time that probably should have. So those are some areas that I've seen coming about.
Yeah, I'll tell you that in the instances where I've consulted with healthcare organizations, I'll go out and interview clinical leaders, and the single biggest complaint, and it's very consistent in every place I've been, is we never know what's going on with our stuff. You know, we submit a work order, we send a piece of equipment down, and it just goes into a black hole. And I think that's become another piece of that quality improvement is, first of all, like you said, create those service level agreements to say, if I get a call for this, I'll name that tune in, however many minutes, for both response. I know it's hard from a turnaround time perspective, but certainly you can have committed response times. And you know what? If you have service contracts or you have an outside third-party service organization handling things, they're going to do that, right? They're going to provide those service level agreements. So I think you have to compete on that level.
I agree. I don't know of any service contract that I've ever came across in healthcare that has not had some kind of service level agreement and measured and reacted to. Yeah. Come renewal time, you're going to pull out those stats of, well, you're 30% of the time you're not even here when you say you're going to be here.
Well, and I think often people are afraid of those, but I've said many times that baseline number, it doesn't matter. It's just a baseline, something that will give you a place to start from, right? And then what's important from that point is what you do going forward, and to be able to track that and identify that you're improving year over year. That's the key. The number itself doesn't matter all that much as long as you're demonstrating improvement year over year.
Agreed.
So, Rick, as I mentioned, there's often fear associated with going down this path, along with the question, where am I going to find time to do all this? We've both seen and heard the same thing around adopting an AEM program. So, from your perspective, what's the return on investment for spending the time to create a QMS program?
Well, you're going to get multiple layers of an ROI on this. Just in resource allocation, I would say within 18 to 24 months, you'll start seeing an improvement on resource availability. You're going to start shifting people away from doing functions and processes that they really shouldn't be doing, right? You have a biomed tech that's spent a significant amount of time in training. They come to you. You want them to be working on equipment. You don't want them to be moving boxes or tracking down where a particular part's at so that they can order it. There's a lot of that administrative function that I think you personally have experienced, Al, in your history, that if you're spending an hour a day per tech and all these non equipment related activities, that's a lot of time. 10 techs, that's 10 hours a day. That's an FTE that you could recoup by doing a good quality assessment, looking at better ways of taking care of those things, and then shifting that responsibility to where it belongs. Besides parts, another one I see a lot in the industry is simply equipment. You have a highly trained, highly paid, often technician that's going around collecting equipment to bring back to the shop for repair. Well, I'm pretty sure you could find someone else that's more apt to be able to just wander around the environment of care and collecting equipment that needs to be repaired and bring it back to the shop. And in doing so, your satisfaction of your team is going to go up. They're going to want to be there to work because they're doing what they love to do. Yeah. It's not that overhead of, oh, here we go again with another one of these things. It's, oh, I get to come in and learn some new equipment or troubleshoot a new issue unique issue I haven't ran across again. Maybe I get to train a fellow employee on something that I know that they don't. but generally the ROI of any kind of cost of this is going to be realized pretty quickly and then perpetually, because QMS is a cyclic event. It's never a do it once and I'm done. You have to constantly look at what you're doing, how you're doing it, how can it be improved, look at the analytics of what you're doing for areas of improvement, and then you implement those changes and you start the process all over again.
Becomes the gift that keeps on giving, doesn't it?
That is correct. That is correct.
Yeah, it's interesting. I actually leveraged volunteers and interns to do some of the administrative stuff that you talked about, or the running, to give techs more time. And when you talked about the parts procurement piece of it, time motion study that I did, the techs were spending on average an hour per technician per day, and at the time I had 80 technicians. Now think about that. That's 80 hours a day. So
that's a lot. Yeah.
I hired a parts procurement specialist, and initially, and then after a period of time, a second one, to offload that responsibility. And you know what? They did a better job. They were able to find higher quality parts consistently, because they had an awareness of what those higher quality resources or vendors were. They tracked statistics around that, things like wrong part deliveries, late part deliveries, DOAs, and again, having those statistics that they tracked helped us improve continually year over year.
Right. And that's what a QMS does on a whole scale across the organization. It's, as we said in the beginning, it's not just the HTM department against the world. It's how can the entire organization contribute to improving the process from start to finish in all areas of the organization, not just in, say, service delivery. So
yeah. Well, Rick, I was going to ask you if you had any final thoughts on QMS, but that sounded like a final thought to me.
Yeah, that's a pretty good one.
All right. Well, Rick, I want to thank you for your time today and for sharing your expertise. I hope the audience found it as valuable as I did.
Well, thanks for having me, and I look forward to maybe doing another one.
Thank you, Al and Rick, for a great presentation. If you enjoyed today's episode, you might also enjoy our ongoing webinar series, Webinar Wednesday. You can find a calendar of upcoming live webinars as well as an archive of on-demand webinars at WebinarWednesday.live. To obtain your certificate for one continuing education credit from the ACI, please remember to click the link located below this podcast title to complete today's survey. If you have any questions, you can reach us at webinar@mdpublishing.com.